Thank you. Our next speaker is Dr. Arundhati Anshu, and she'll be speaking on DSAEK management of complications and long-term outcomes.
Hi everyone. I've been following the talk in the morning about when to do DSAEK and when to do DMEC. I think this is just nice because despite the fact that there has been an increase in the number of DMECs the world over, we still continue to do DSAEK for a select group of patients. And especially when you're a novice surgeon, for the complex cases, it's best to stick to DSAEK, which is a lot more easier to manipulate in the eye. So I'll be going through some of the complications that are encountered in DSAEK, which could be intraoperative or postoperative, both in the early period as well as in the late stages, and how best to manage them. Fortunately, with the advent of EK, suprachoroidal hemorrhage is quite uncommon. Manual donor dissection, there's always a risk of perforation, but now we've moved away to doing it automated, and so the risk is much lower. But even then, you can still get perforation, so now we get the eye banks to do it. That helps to reduce some of the stress on the surgeons, and so we tend to get a lot more predictable donor corneas in patients going for DSAEK. There is always some problem with posterior lamellar donor preparation because we know when we have the cut created, there is a difference between the central and peripheral corneal thickness, which is also responsible for some of the hyperopic shift. These thick edges, especially in our Asian eyes, can be sometimes challenging, resulting in angle crowding and pupillary block. But with thinner donors, these problems can be mitigated, and of course with DMEC, this does not arise at all. Some of the common complications in the early stages is conversion to PK intraoperatively if the patient has a primary graft failure. In our early series, the risk of conversion to PK was very low, and there is this whole host of papers that have been published on the rates of dislocation following DSAEK. In our series, in the early stages, we found that our complication for DSAEK was less than 1%. And as you can see, the variation in dislocation rates depending on the type of technique that you use for doing DSAEK, as well as in the early learning curve when there is a higher rate of dislocation. Some of the things that have been introduced to reduce this risk of dislocation is venting incisions, scratching the periphery of the recipient bed, having a complete air fill, massaging any fluid from the interface, especially through the surface drainage venting incisions, leaving a full air fill at least for 6 minutes. Now, a lot of studies have shown that you need a minimum air fill for 6 minutes. And now, in recent years, I don't tend to remove any of the air, and I leave the eye with a full air fill and have a PI there so that we know that the patient is not going to get a pupil block post-op. Of course, you have to keep in mind that with venting incisions, there is always a risk of epithelial ingrowth and infections at the site of the venting incisions. Pupil block glaucoma, again, variably reported in literature. We have very low rates of pupil block because we tend to do a PI for all our cases. And I think the world over, a lot of the surgeons have now started doing PI, resulting in a lower risk of pupil block post-DSAEK surgery. Iatrogenic graft failure or primary graft failure, it used to be a lot more in the early years when DSAEK was first started because of the steep learning curve with improvements in techniques and technologies. Now, of course, the rates of graft failure have gone down significantly. And in our series on the endoglide, the rates of graft failure were less than 1%. So we also looked at a study to see what were the graft failure, donor and surgical risk factors for graft failure. We looked at several parameters, and we found in a multivariate analysis that the only thing that stands out is the donor insertion technique as a significant risk factor for iatrogenic primary graft failure. What about late complications? Graft rejection, again, variable reports in literature from 2 to 45%. In our series of more than 600 cases in the early phase was about 10% of cases. And compared to PK, a lot of these patients can be asymptomatic or have very mild symptoms that may sometimes be mistaken for something which is innocuous and not a rejection. So, and not all of them have KPs. They may have a little bit of edema. And rejection line is very uncommon following a DSAEK graft. And if it's not treated in a timely manner, more than 7% to 10% of patients can progress to failure. So this is a very good paper published in 2009 by Price et al., who showed that the probability of a rejection episode was the highest in the first 2 years of surgery, So at our center in SNEC, we make sure that we follow these patients closely for the first 2 years of life, 2 years post-transplant, at least at 3 to 4 month interval. And thereafter, if they have remained stable, we can see them on a yearly basis. Of course, this study also showed that African Americans had higher risk compared to Caucasians in eyes with pre-existing glaucoma, or steroid-responsive ocular hypertension, were also increased risk of rejection. What was also interesting in this study was there was no increase in rejection when the fellow eye was grafted within 1 year. So there has been a shift or a trend to doing the other eye within 3 to 4 months post-surgery, as long as the first eye has been stable. This is another paper by Wu et al. In AJO that again showed that the risk of rejection was highest in the first 2 to 3 years post-transplant when you need to follow them up. And a cessation of steroids had a very high risk of increasing the risk of rejection. So I think the world over, a lot of us still will continue these patients on at least minimal low-dose steroids in the long term. How do we manage these patients with rejection? I think high vigilance, counseling, and making sure that you have a good support system in the hospitals to make sure the patients can come in if they have any symptoms, and of course, intensive topical steroids. A lot of these patients can be, they can recover just with topical steroids alone. Occasionally, if there is significant edema, they may require oral steroids as well. And these are some of the differential diagnoses to keep in mind when patients come in with symptoms and signs suggestive of rejection, late graft failure, sterile endophthalmitis, epithelial downgrowth. Of course, you can do, if you are in doubt and you see a white membrane on the iris in epithelial downgrowth, an argon laser test can be useful. And of course, in our part of the world, CMV, because a lot of cases of rejection may actually be mimicking a case of CMV. So this is our first few cases of CMV post-DSAEK. We've had several now, more than at least 50, 60 cases of CMV post-DSAEK or DMEC surgery. And so this is something that we always keep an eye on. If a patient has got symptoms and signs suggestive of rejection with high intraocular pressure, have those typical coin-shaped lesions, or even pigmented KPs, not just in the graft, but also beyond the graft-host junction, it's highly suspicious of CMV, and it's important to tab these patients either preoperatively if you're going to get this patient to surgery, or at least during the surgery, and then monitor them post-op. How about raised IOP? I guess we see a lot of the patients with DSAEK, at least a third of them develop. And these are some of the questions we want to know when you have a patient with raised IOP. What's the incidence of high IOP? What is the effect of raised IOP on post-DSAEK patients with pre-existing glaucoma? And what are your management options if they develop post-DSAEK IOP? So in short, if a patient has had DSAEK, it's very comparable. So a third of patients, similar to PK, can develop a high IOP post-operatively, and there are no specific risk factors that have been identified for post-DSAEK glaucoma yet. And what about IOP after DSAEK? Again, over 2 years, higher failure rates if patient has got pre-existing glaucoma versus no glaucoma. And if you need to do a glaucoma surgery post-DSAEK, most often it has been suggested that tubes are not good, especially for post-PK. It was suggested that a tube is a better option because these are high-risk eyes. But we realized that I think a trabeculectomy is a good first attempt in patients who need glaucoma surgery post-DSAEK. Again, cataract formation and late endothelial failure. So to conclude, early complications can be improved with newer techniques, with resultant reduced dislocation rates and IPGF. Late complications can still happen even with lamellar surgery, so it's important that you have long-term follow-up to ensure that the patients have the best outcome.
Thank you very much.
Thank you.
We have time for maybe a question from the audience. I have one. You said that you have showed a series of DSAEK cases at SNEC, and the only risk factor for graft failure was the insertion technique. I find that very surprising because pretty much every other big series, including, for example, the cornea preservation time study, which was 1,300 cases, showed what we all know, which is that prior glaucoma surgery is the probably most important risk factor, but others, such as presence of ACIOL, intraoperative complications, etc. Was that series, did that exclude patients from prior glaucoma surgery or ACIOLs, other known risk factors for failure? Early failure.
You're talking about primary graft failure.
So primary graft failure.
Yes, yes.
Got it. Okay. Thank you. Okay, I was trying to reconcile that with the rest of the other literature, so that makes sense. Thank you for
No, it's primary graft failure.
thank you
yes.
for explaining
Okay,
that.
yeah.
Appreciate that. Very nice.